Hi my dear friends, today we will discuss in this video presentation primary open angle glaucoma. As a background, glaucoma is a group of irreversible progressive optic neuropathy that can lead to severe visual field loss and blindness due to optic atrophy. Glaucoma may be primary or secondary glaucoma. In primary glaucoma, the elevation of the intraocular pressure is not associated with any other ocular disorder, while in secondary glaucoma, there are ocular or non-ocular disorders alters the aqueous outflow and lead to elevation of the intraocular pressure. Primary open angle glaucoma, which is our topic today, it can be named as chronic simple glaucoma. It is generally bilateral disease but not always symmetrical. It is characterized by adult onset, intraocular pressure more than 20 mm mercury, open angle of normal appearance, glaucomatous optic nerve head damage like in this photo, and visual field loss like this photo. Incidence of open angle glaucoma primary type. It is the commonest type of glaucoma and affects about 1% of general population more than 40 years old. It more liability to occur in old ages rather than younger age. As regards sex, it affects both sexes equally. As regards age, most cases more than 65 years. It is unusual to be found in persons below 40 years old. As regards race, more common and earlier presentation and more severe in black people. So black people are highly liable for open angle glaucoma with early presentation and severe course of disease. Lastly, as regards laterality, it is a bilateral disease but one eye affected before the other. Risk factors and association. The first risk factor is family history and inheritance, as primary open angle glaucoma is frequently inherited. The second risk factor is myopia. We can see primary open angle glaucoma in cases of myopia with high incidence. The last risk factor is retinal disease, as in cases of central retinal vein occlusion and in cases of retinitis pigmentosa like this photo. Symptoms. Early it is asymptomatic, no manifestation, while late there is significant loss of visual field which occurs gradually. So it is an insidious onset of loss of vision. The patient can't detect it. So many patients come to us in late stage. But as regards bilaterality, patients therefore frequently present with significant visual field loss in one eye and less advanced in the other eye. Like this photo, you can notice that one eye is more advanced rather than the other eye. Signs of primary open angle glaucoma include intraocular pressure. The main character here is raised IOP more than the normal, which is 20 mm mercury. The second character of a change in the IOP is diurnal fluctuation. Diurnal fluctuation in glaucoma more than 5 mm mercury, which means when we measure the IOP at night, it will be different from the measurement of the IOP at daytime. This difference more than 5 mm mercury means that there is a diurnal fluctuation which is exaggerated in cases of primary open angle glaucoma. The third character of the IOP changes is asymmetry of the IOP between two eyes. When we measure the intraocular pressure in one eye, we will find that it is higher or lower than the IOP in the other eye. Other signs is optic disc changes. One of the characteristics of primary open angle glaucoma is optic disc changes, which include bearing of the curvilinear blood vessels crossing the optic disc, like here. Vessels appear due to lack of support of the ganglion cell axon. The second change we can find is optic disc hemorrhage, like splinter hemorrhage or flame-shaped hemorrhage. The third change is nasalization of the central blood vessels. Here, central other vein not supported by the axon of the optic nerve fibers, so nasalization will occur due to lack of support. The fourth change is enlargement of the physiological cup. Usually, the physiological cup not more than 0.3 of the optic disc diameter. Here, primary open angle glaucoma, the diameter of the physiological cup increases more than that. And the last change is asymmetrical cup disc ratio between both eyes. When we examine both eyes, we will find a difference between the size of the cup between both eyes. Lastly, there is a specific glaucomatous cupping character, which include narrow opening of the cup, like here. Size of the cup is large cup, and the depth very deep to inside and overhanging edge as like that. We can notice in this photo that there is overhanging edge and increased cup disc ratio more than 0.3 as we mentioned before. And lastly, in advanced cases with glaucomatous optic atrophy, we can see the lamina cribrosa due to loss of optic nerve fibers which are damaged by glaucoma. Another important sign is visual field changes, which measured by perimeter. Here, these two types of changes, central changes and peripheral changes. The central changes include first, paracentral scotoma, an isolated island which later become with the blind spot forming the arcuate scotoma. The second change is pairing of the blind spot. It means that the blind spot is excluded from the central field due to localized contraction on the temporal edge of the central field, like here. We can see that the blind spot is excluded from the central field. The third characteristic change in the central change of the visual field is scotoma, which is a tapering wing-like elongation of the upper or lower pole of the blind spot. Like the fourth characteristic visual field change is scotoma, which is upper or lower bundle field defect around joining the blind spot around the fixation point. Like here we can see that there is a scotoma connected to the blind spot. And the fifth change is annular scotoma, which occurs by fusion of two scotoma, upper and lower, in the nasal field. As regards the peripheral changes in the visual field, we can notice that there is nasal field contraction, which usually occurs earlier than the temporal field because the temporal retinal fibers are more dense and suffer more. The second peripheral changes in the visual field we can mention like nasal stem, which is sectoral nasal field defect, upper or lower and with sharply horizontal edge, like here. The third peripheral change in the visual field is concentric contraction, and lastly tubular vision. Like here we can notice that there is an area of field defect with central tubular vision. This is the device of measurement of the visual field, which is called perimetry or Humphrey visual field machine, which one of the static perimetry devices. The fourth sign which is important in diagnosis of primary open angle glaucoma is gonioscopy, which shows a normal open angle. Here in this photo, it is the gonioscopy of the angle of the anterior chamber, and here we can see all structures of the angle, which means that this angle is open and normal. As regards the treatment of primary open angle glaucoma, there are different measures to treat primary open angle glaucoma. Here, the main aim of the treatment of primary open angle glaucoma is to prevent functional impairment of vision within the patient's lifetime by slowing the rate of ganglion cell loss. The method of achieving this goal is by lowering of the intraocular pressure. This is an important term we should mention, which is called target pressure. Target pressure is an IOP level below which further damage of optic nerve is unlikely, and our therapy should maintain the IOP at level below the target level. Target pressure, we know it after treating the patient, and by follow-up we will know the pressure below it. No further damage occurred to the optic nerve, which is called the target pressure. So the treatment should maintain the IOP below the target pressure to prevent ganglion cell loss by glaucoma. Monitoring of this patient is mandatory by optic nerve examination and by visual field to prevent the further damage of the optic nerve. Also, monitoring of the target pressure is mandatory. Lines of treatment of primary open-angle glaucoma. There is three main lines: medical and by laser treatment, and lastly by surgical treatment. Medical therapy. Basic principles, which include topical eye drops. Any chosen drug should be used in its lowest concentration. Initial treatment is usually with one drug, and then we can add another drug later on if we need. And lastly, follow-up is mandatory for these patients. Anti-glaucoma drugs mostly are topical eye drops, and they include beta blockers, alpha-2 agonist group, prostaglandin analogs, topical carbonic anhydrase inhibitors, and systemic carbonic anhydrase inhibitors, which can be taken by injection or orally, and lastly hyperosmotic agents, which can be taken also by injection or orally. Hyperosmotic agent like mannitol given by intravenous infusion. We will discuss the anti-glaucoma drugs in a separate presentation. Laser treatment. Here in primary open-angle glaucoma, the main laser treatment modality is laser trabeculoplasty. Laser trabeculoplasty, in this procedure, discrete argon or diode laser beams are applied to the trabecular to enhance aqueous outflow and lower the IOP. In this technique, laser beams will elect some sort of inflammatory reactions, and inflammatory cells like macrophages will take all debris which can be present in the trabecular meshwork pores, and here increasing the aqueous outflow. Often transient effect lasting for few years, so laser trabeculoplasty therapy may delay the need for filtration surgery, but patients here should be monitored, and we can use another drug for treatment of glaucoma with this technique. Surgical treatment. Lastly, the last option for treatment is surgical treatment. Here we do surgery called trabeculectomy. In this surgery, it's done by surgical creation of a fistula between the angle of the anterior chamber and the subtenon space. This fistula will allow the passage of aqueous from the anterior chamber into the drainage blip under the upper eyelid. So it is called sterilizing operation. We do by it a fistula between the anterior chamber and the subtenon space, so aqueous will pass from inside the anterior chamber to this fistula to the subtenon space, and here we cause drainage of aqueous in another pathway than its regular drainage. The indication of trabeculectomy. The main indication is failed medical therapy or failed laser trabeculoplasty. The second indication is advanced diseases requiring very low target pressure. So in these cases we will use trabeculectomy to take the patient side to avoid vision loss in the future. Thank you, and I hope you enjoyed my presentation. Thank you very much.